Today, I want to go over some of vascular access, mainly the journey of vascular access over the years. I have no disclosures.
Hey, Sheena, sorry, I don't see your screen. I don't know if I am the only person. Sorry.
I see the screen, but it didn't advance.
Okay.
Now
Oh,
it
now
has.
we see it. Yeah.
Oh.
Thank you.
I think I hit pause by mistake. So I'm going to divide my talk into 4 categories. And in the first part, I'm going to have a brief review of the history of vascular access journey in the last several years since the start of it. And then go on to explore the determinants of vascular access outcomes, then look at the role of kidney disease education and nephrology care on vascular access. And then finally, look at some of the disparities that exist in our ethnic minority groups in relation to vascular access. So from timeline, as you all know, it's been about 100 years ago from now that the first artery vein glass cannula was introduced in an attempt of the early vascular access. And then about 20 years later, they developed a metal trocar to connect an artery and a vein. And subsequently, the beginnings of what we know of the Scribner shunt started with the all-wall shunt, where they had a polyfluoroethylene material tubing that they used to connect an artery and a vein. The first fistula that we know as of now was created in the 1965s with arterial venous graft starting in the 1969s. And our percutaneous catheters that we use did not come about till the 1980s. And the most recent development, of course, is our percutaneous endovascular fistula placement in the last 8 years. So as you all know, there's several sites of AV fistula placements, the most common being your radiocephalic, either the snuff box or the distal, and the brachiocephalic being the 2 most commonest site that we place AV fistulas. With regards to graft, the 2 most common is your brachial and the antecubital forearm, and your brachial and your axillary loop that you use for AV grafts. Now, a fistula maturation depends on 2 main factors: your vasodilatation, or what's meant as the outward remodeling, and your intimal hyperplasia, that's the inward remodeling. Now, in a healthy vein, you have you have a normal-looking vein, which then has a more favorable chance of developing a fistula. Compared to our CKD vein, even before they start dialysis, they have already some intimal hyperplasia, which sets them up into a less favorable setting when an access is planned to be placed. And it's thought that a perfect balance between the 2, with more outward remodeling than intimal hyperplasia or inward remodeling, is what creates an optimal fistula. And as you all know, the commonest sites for AV fistula stenosis is your outflow tract in the vein, followed by a juxta-anastomotic stenosis or the inflow stenosis as the second less common sites of stenosis. So when you look at vascular trends over the past 20 years, this is worldwide prevalent vascular access trends. So for my fellows on the talk, when I mention prevalent, I'm talking about all hemodialysis patients, all patients on hemodialysis at this time, and incident, meaning the patients who initiate dialysis at a time. And if you look, Japan, even in the 90s, had the highest rate of arteriovenous fistula and graft in the high 90s, compared to the US, which only had about 24% of AV fistula usage in the late 90s. So this is Dobbs data from 1996 to 2007. And this led to and when you look at incident vascular access at the same time, again, Germany and Japan, 75 to 80% of patients started with a fistula or a graft compared to 16% in the US and 15% with an AV graft at that time. So this led to the initiatives that we know. So the Fistula First initiative that started after Dobbs 1 came out. And the unintended consequence of this was that there was an increasing proportion of central venous abscesses because a percentage of AV graft creation was markedly reduced when we went with the Fistula First initiative. This led to the change in that initiative from Fistula First to Fistula First Catheter Last in 2007. And that's the initiative that we continue to use at the same time. So when you look at the Dobbs data over the years from phase 1 to phase 4 and 5, we really did well from having a 24% AV fistula rate in our prevalent HD population down to now most recent, and this is also the current usage, of having about 70% of AV fistula rate in our prevalent hemodialysis population. But what we did not change is that the CVC rate in our incident hemodialysis patients still continue to remain about 70% in spite of all these efforts. So let's look at some of the determinants of vascular access choice and outcomes in these populations to see, can we do better in terms of increasing the access incident population. So the reason why this came about as to the type of access and the choice of access is from one of the landmark trials, which is the CHOICE trial from 2005, where they looked at the survival of hemodialysis patients depending on their vascular access. And what they showed was that the patients who had a catheter, when you looked at cumulative mortality, seemed to have a much higher mortality compared to patients who had fistulas, and the graft kind of fell in between. And this was about 600 patients. This led to a bigger study that looked at much higher number of patients, so 220,000 patients. And basically, this showed the same, that having a fistula or having a graft with a catheter and a fistula had the best outcomes compared to having a catheter alone or a catheter with a graft. And subsequent studies have all shown similar in terms of mortality, that having an AV fistula or a graft has much better mortality compared to catheter. Now, does the location of your AV fistula matter in terms of outcomes? And this study looked at patients who were younger than 65 and patients who were older than 65 and divided them into male and female. And they found that in patients who were less than 65, there was no statistical difference whether the fistula was placed in the forearm versus fistula placed in the upper arm. But compared to older adults, more than 65, and female patients, they seem to have an increased primary failure rate with forearm fistulas compared to your upper arm fistulas. What about the timing of vascular access? We say that the incident hemodialysis patients are starting with a catheter, but is there any benefit in pushing for that catheter that access to happen before? And they looked to see if patients who had been on dialysis for at least looked at 24 months of being on dialysis, and they looked to see patients who had no fistula attempts and fistula attempts with regards to age. And they found that patients who were younger than 65 had a much more favorable mortality outcome having a fistula, along with patients who were older than 65 within that first 24 months of being on dialysis. After 24 months of being on dialysis, the placement of a fistula really did not affect their mortality. And this data was adjusted for BMI, sex, cerebrovascular accidents, CV, heart failure, coronary artery disease, peripheral vascular disease, and all the other comorbid conditions. So one of the thought was that maybe the excess mortality that we see in our patients with catheter may not really be due to the fact that they had a catheter, but it may be more due to the fact that they are the sicker patients who have a lot more comorbid conditions and who really are not ideal candidates to get a fistula. Now, what about the cost of access? Now, we know that traditionally an AV fistula cost is thought to be much lower compared to patients who had a graft or a catheter. And this is true if you look at a fistula that had needed no procedure done and had no primary access failure, that the cost was about $6,000 compared to $16,000 in a patient who started dialysis with a catheter, had an AVF created after dialysis therapy, and required at least one additional procedure to maintain patency. So when you take the latter into consideration, the cost significantly went up, with AV fistulas needing about $59,000, followed by AV grafts, which needed a higher amount of $73,000, with the CVC being the most expensive at $79,000. Now, the other economic implication of these access surgeries is looking to see what percentage of the accesses that were placed actually went on to be successful to be used. So this study looked at about 479 patients on dialysis who did not have an access when they started, and then subsequently went on to have either an AV fistula or a graft placed. And around 36% of patients, the fistulas failed to mature on that first attempt. And out of those, 46% initially needed an intervention for it to work. And this graph shows the number of accesses placed when these patients were followed over a 4-year period. And as you can see, at least 30% of patients needed more than one access placed in order to get a functional AV fistula or graft. And another 10 to 15% needed 3 accesses placed before they were able to have a functioning access other than a catheter. So the cost in terms of needing a fistula compared to a graft actually seemed to be higher in the fistula compared to the AV grafts. And when they looked to see if the cost had any difference based on comorbid conditions, so diabetes, heart failure, age, males and females, there seemed to be more cost associated in AV fistulas in patients who were diabetics, in older adults, and in patients, in male patients, as well as in patients without congestive heart failure. That being said, the cost of access-related procedures was definitely higher in your catheter group compared to your AV fistula. Now, the other question was that, is the lower risk of mortality associated with the fistula use due to the avoidance of catheters, or is it more that healthier patients have fistulas? And the Canadian looked at this cohort of 2,300 patients that they matched in comorbid conditions. And they looked to see if, looked at rate of catheter-related bacteremia and the cause of death in those patients. And the dark line on top of the graph represents access-related deaths, and the rest, the clear area, represents non-access related deaths. And what they found was that majority of deaths in these dialysis patients were not related to catheter complications. Now, how we take this data may differ because Canadians at baseline have a very low infection rate. In fact, they have an average of one catheter-related bacteremia every 5 years compared to a much higher incidence in the United States population. And with this data, in the last few years, Canada has actually switched where their catheter use has gone up compared to AV fistula and AV graft use with similar outcomes. The next question is there a difference when you look at patency survival of a fistula when you compare it with a graft? So this study looked at about 1,100 hemodialysis patients, again, a Canadian study, and they took out all patients who had a primary access failure, and then they looked to see over a 10-year period, the survival of a fistula compared to a graft. And when they took out the primary patent fistulas, or when they excluded the primary failures, AV fistulas did much better than the graft, but when they included the primary failures, there really wasn't a big difference at a 10-year mark whether the fistula or the graft remained patent. And a later study in 2019 looked at similar to see what are the best options in terms of access survival. And this group showed that the best was an AV fistula, which did not need any intervention, followed by an AV graft, which did not need any intervention, followed by an AV fistula that needed intervention, and lastly, an AV graft that needed intervention. So, I'm trying to shift the focus where we always recommend a fistula that it might not be the right choice in certain subset of patients. The next part that I want to highlight is also, do we really have to be careful with vascular access selection in our elderly patients to start with a catheter? And this was USRDS data of about 9,400 patients who initiated dialysis with the catheter. And they looked to see, all patients who got a AV graft or AV fistula within that first 6 months. And what they found was that of the 7,000 patients that did get AV fistula and 2,000 that got a graft, 51% of them had an unsuccessful use of the vascular access. And about 49% had a successful use. And when you looked at those subset of patients, there were a good number of 42% that needed interventions to make that successful. And then primary patency loss in about 73 of those patients. So at the end, concluded that even though in elderly patients that received the AV graft and AV fistula, the successful chance of getting a fistula may be limited. And when you look at need for interventions prior to use in that same cohort, the AV grafts had much lesser time of months on a catheter compared to an AV fistula that needed intervention, being on a catheter for 2 months versus being on having a catheter for about 5 months, which was statistically significant. So to conclude this part of the talk, I want to focus on some of the myths and kind of bring out facts that have changed over the years. Is that AV fistulas have a better survival than AV grafts. So when you include AV fistulas that fail to mature, the secondary survival is equivalent in both AV fistulas and grafts. AV fistulas are cheaper than AV grafts. But if you analyze by intention to treat, then AV fistulas are more expensive, or at least equally expensive compared to a graft. Now, we've always been taught that you should access forearm fistulas or use suggestive forearm fistula first before an upper arm, so that we maximize the availability of accesses. But more and more patients these days are getting an upper arm fistula because they have a higher superior maturation rate compared to a forearm fistula, especially in the subset that I showed you. And that AV fistulas fail to mature primarily because of aggressive neo-intimal hyperplasia. And now we know that it's not just the intimal hyperplasia, but it's more of a balance between the outward remodeling with the intimal hyperplasia. And lastly, that CVCs are a major cause of death, and that, the shift into the thinking that CVC may be a surrogate marker of a much sicker patients, and that very few deaths in patients are directly related to CVC complications, and more indirect, more related to being a sicker cohort. So with that, I want to focus on the third part of my talk, which is the role of kidney disease and nephrology care on vascular access. So we know well from our own Dr. Shukla's work that patient education increases home dialysis usage. And looking at this analysis of several publications over the last 20 years, this has been consistently shown. We also know from the DOPS data that nephrology care of more than 4 months resulted in CVC use only in 36%, compared to the cohort of patients who had nephrology care for less than 1 month, where there was about 77% rate of CVC use. Now, the other question is, does the role of nephrology care in vascular access have any implication in terms of the duration? So does longer duration of having nephrology care improve outcomes in dialysis patients? And we know that in this USRDS cohort, that there are several factors that have been shown to be beneficial or favorable in patients with nephrology care or longer nephrology care. And by longer, I mean more than 12 months. So the albumins are higher, hemoglobins are higher, the choice of home dialysis is higher, and access to transplantation is higher. Now, from our talk's perspective, having a vascular access, so a graft or a fistula, when patients have had nephrology care, they're 6 times more likely if they've had nephrology care up to 12 months, and double that amount if they've had nephrology care for more than 12 months. So duration of nephrology care seem to have an effect on vascular access choices. We also know that pre-dialysis nephrology care affects mortality, especially in the first year of incident hemodialysis. So this looked at mortality for 12 months with patients who had no care, who had less than 6 months care, 6 to 12 months care, and more than 12 months care. And as you can see, much higher mortality in the patients who had less nephrology care compared to patients with more nephrology care. And again, data from our own group, Dr. Ruchi and Dr. Shukla's work showed that there seemed to be a role of kidney disease education in the vascular access choice. And when they looked at incident AVEF use and AVG use, along with any catheter use, in 82% of patients with no kidney disease education, there was a higher catheter use compared to 65% in patients who had some degree of kidney disease education. And similarly, you could argue that the patients with health insurance before dialysis may affect their access to pre-dialysis nephrology care, which may also affect vascular access choice. So, this study looked at all patients, and we know that once they start dialysis, they're eligible automatically for Medicare, Medicaid. So they looked at all patients who started dialysis with a catheter, and they looked to see if having that insurance barrier led to any change in terms of their vascular access. And what they found was that the cohort that did not have insurance at the time of start of dialysis tend to have a lower likelihood of having AV fistula or AV graft compared to those patients in both Medicare and Medicaid that had dialysis at the start of had insurance at the start of dialysis. And this difference in terms of having insured, the difference in this group did not change, or did still stayed significant even 12 months into having started dialysis. So that seems to suggest that having insurance prior to dialysis initiation did affect vascular access outcomes, even in the long duration after they receive insurance. And the other part that when they looked at the same study cohort, was that the rate of, as I mentioned, the rate of AVF and AVG, even after 4 months, was higher in the patients who had insurance compared to the patients who did not have insurance. And the risk of infected catheters were much higher in the uninsured population compared to the insured population. And that the patients who started dialysis on Medicare were still significantly more likely to use a fistula or a graft at the 12th month mark compared to the uninsured. So with this in mind, I want you to bring your focus onto the recommendations by KDIGO in their vascular access recommendations from 2020. And what they suggest is that when you consider pre-dialysis kidney replacement therapy, the first step to look at is, what is the likelihood of long-term survival for this patient? Irrespective of age, you're looking at, age is obviously a consideration, but also comorbid conditions, the functional status, social support, patient's goals and preferences. And if that is poor at that beginning of your assessment, then wait and watch and reassess approach may be the most appropriate in that point. And then reassess at a point to see, has that situation changed? If that hasn't changed, then the discussion to the patient may need to be more about, is the plan to do hemodialysis more of a palliative hemodialysis, meaning that we may not change their outcomes, but more of a patient preference? And at that point, consider referring them either for an AV graft or an catheter, depending on patient preference. Knowing that the AV graft may be more having a higher success rate in this really sick population, and may be able to limit their time needing a catheter, or may have a quicker access to cannulation compared to an AV fistula. Now, if when you review their pre-dialysis consideration, you think they're a good candidate, at that point, you want to assess their appropriateness for an AV access. And if you think that they would be a good candidate for an AV fistula, depending on age, comorbid conditions, how good their vasculature is, if they have significant peripheral vascular disease, etc. At that point, then you refer for a fistula. And if, when you consider all these points and you don't think that patient's going to have a successful AV fistula, it may not be unreasonable to refer the patient for an AV graft. And then consider if a secondary AV fistula is possible at that point. So the idea is to have a more tailored approach to considering an access compared to our previous thought of having a fistula first. So this leads to the last part of my talk, which is mainly looking at disparities among ethnic minorities with regards to vascular access. So we know from previous publications that racial and ethnic disparities occur in association with initial hemodialysis access. And this study looked at about 400,000 patients and looked to see if, looked at the difference and found that, looked to see in terms of the AV fistula usage in white, Black, and Hispanic population. And they found that 18% or the white population tend to have a higher rate of AV fistulas compared to both the Black and the Hispanic population. And we know that Hispanic population has an increased risk of a CKD similar to the white population, and in the highest cohort being Black population. But the big factor is that the rate of ESRD or ESKD is 50 times greater in our Hispanic Latino population compared to the other cohorts. And in that population, in this large population cohort, which had a decent amount of the ethnic minorities, there was an increase in CVC, so 11% increase of getting a catheter in our African-American population, and a 9% increase in getting a CVC in our Hispanic population. The fistula maturation for our minority groups was actually higher once they got a fistula, and mortality was actually better for our ethnic minority groups compared to the Caucasian population. Now, once they got a fistula, the patency was also higher for Hispanic population, but the patency was least for our African-American population. And we know that from previous studies that African-American population tend to have a higher incidence of AV grafts because of having smaller vein diameters, as well as having the increased risk of failure of vascular access. Now, again, I'm not sure why my slide is advancing without my prompting. But again, when you looked at patient survival having AV fistulas, whereas AV graft, sorry for this, the white population did worse compared to the African-American and Hispanic population in both groups, AV fistula and graft groups in this cohort. Now, one of the things they also looked at was, does insurance play a role in vascular access decisions for this minority cohorts? And, it was found that patients who with or without insurance, Black patients and Hispanic patients initiated hemodialysis with an AAV fistula less frequently than white patients. And Black patients obviously had an increased incidence of AV grafts compared to both the Hispanic and the white patients. They also looked to see if nephrology care, having increased duration of nephrology care, actually had an effect on these minority groups in terms of better access preference. And they found that increased duration of nephrology care, actually fewer Black patients and Hispanic populations initiated hemodialysis with a fistula. And irrespective of nephrology care, again, Black patients received an AV graft. And this begs the question, are there other social or cultural aspects that we need to consider to help these patients, even with nephrology care, to improve their access outcomes? Now, as I mentioned, in our African American population, there is a disparity between AVF placements, and there's also a disparity. So this study looked to see if you take all patients who started hemodialysis with a venous with a catheter, was there a difference in terms of the ethnic cohorts as to AVF placement, successful use, and patency? And they found that in all three categories, Caucasian patients did better in placements having a successful use as well as maintaining primary patency compared to Caucasian Black population. And the same when it looked at outcomes by race, Black population was less likely to have an AV fistula placed. They were less likely to have a successful fistula placed, and less likely to maintain their patency when followed for 3 years or so. So as you can see, there's several hurdles that that access placement needs, that access placement in this minority has to jump through, with all a lower incidence in several of these steps and not just one. That makes it challenging. So to recap, I went over vascular access role in ESKD outcomes. We looked at pre-dialysis nephrology care and kidney disease education and the important factors that affect vascular access, and the disparity that exists between the ethnic groups. And now in the subsequent slides, I want to go over some of the work that I've been fortunate to do with Dr. Shukla's team in continuation to the data that we are looking at the minority. So we know that in the road to looking at outcomes, there's several areas where interventions are possible, or several steps where disparities can occur. So pre-ESKD care, then ESKD treatment and selection, dialysis care, and then outcomes. And out of these areas of inequalities, it can be in the health insurance, access to nephrology care, modality selection, referral for transplant, and several changes as in Affordable Care Act and Advancing American Kidney Health has been proposed in order to affect the change better in each of these categories. Now, this is data from Dr. Shukla's group that was just accepted for publication, where they showed that disparity in pre-dialysis nephrology care significantly influenced home dialysis use in our Hispanic and Black individuals. And that longer duration of nephrology care and kidney disease education had a sustained impact on home dialysis use in this cohort. And in a continuation to that, we aim to look to see the care disparities in pre-dialysis nephrology care and kidney disease education on vascular access disparities in the ethnic minorities. For the interest of time and for the data that has been reviewed, I'm going to focus on the Hispanic cohort and not the African American Asian cohort in this talk. And this is looking at data for hemodialysis patients who've had at least 6 months of Medicare. So that's about 427,000 patients, in which the white cohort is about 269,000, Hispanic about 46,000. And the areas that were looked at was no nephrology care, care more than 6 months, and pre-dialysis kidney disease education. I just want to highlight that the kidney disease education cohort was low in both groups and really low in the Hispanic groups. And we used mediation analysis to dissect the attributable influence of the disparities in pre-dialysis care and KDE on the incident vascular access use. So in the patient characteristics, I want to highlight mainly our Hispanic cohort is that the Hispanic and Black population had ESRD at a younger age. They had lower BMIs, higher diabetes and hypertension burden, less pre-dialysis nephrology care, less pre-dialysis kidney disease education, less AVF use, with AVGs being more prevalent in our African American. So before I go on to the results, I just want to go over the causal mediation model, which was used in order to study the association. And I want to give an example of a non-medical analogy is that, so the idea is that the exposure has a direct effect on the outcome, and then there's also an indirect effect through the mediator. So for example, if I take exercise as the exposure, we know that exercise has a direct effect on weight loss. And if I add dietary habits as a mediator, I'm saying that the exercise improves your dietary habits, which leads to weight loss. So similarly, ethnicity has a natural direct effect on vascular access. And we've seen that data on the previous slides. Now, what we are looking to is a natural indirect effect of nephrology, pre-dialysis nephrology care and kidney disease education. And in this model, the total effect is a multiplied effect of both the natural direct effect and the natural indirect effect. So when you look at, the study outcomes for the direct path, so exposure to outcome, we see that there's Hispanics have a 23% less likelihood of getting an AV fistula. They have a 20% less likelihood of getting an AV graft, and 17% more likelihood of getting a CVC. And this is without the influence of pre-dialysis nephrology care. Now, when we look at the Hispanic population mediated by nephrology care, we see that Hispanic population has 30% less likelihood of nephrology care and 35% less likelihood of more than 6 months of nephrology care, and 37% less likelihood of receiving pre-dialysis kidney disease education. And when you look at the outcomes by the mediators, the white population had a 4.8 times more likelihood to receive kidney disease education compared to, and the white population also had 15 times more likelihood of getting an AV fistula and 79 times less likely to get a catheter compared to the Hispanic population when you add in the mediator. So when you look at the causal mediation model, we look to see the outcomes in AVF with CVC alone, AVG with CVC, and then sole CVC with everything else. And we see that, if there was no disparity, so the natural effect, if there's no disparity in the two groups, the Hispanics were 16% less likely to get an AV fistula. But because of this disparity, the total effect was a 23% less likelihood of receiving an AV fistula. Similarly, looking at KDE, if there's no disparity, Hispanics have a 29% less likelihood of getting an AV fistula, but due to the disparity with a KDE, they have 46% less likelihood of receiving an AV fistula. Now, with regards to the sole catheter access, that patients who had nephrology care had 4% less likely chance of getting a CVC compared to 21% chance of likelihood of getting CVC, and then a total effect of an 8% higher chance of getting CVC. Now, you could argue that this seems counter to what we would think. And the thought is that maybe the referrals for nephrology care and KDE was very late, that it didn't influence the decision. And also there was a much smaller cohort of KDE to study in these two populations. So the conclusion is that approximately 1/3 of the disparities exhibited between the ethnic backgrounds in vascular access modality is due to pre-dialysis nephrology care disparities. And addressing these factors may improve disparities in vascular access outcome in this in this cohort. Now, obviously, the limitations is that, as I mentioned, the KDE services are very underreported. Then only more than 6 months of Medicare coverage was included. So we did not include anybody that had less than 6 months. And then there seemed to be, in terms of disparate influence of nephrology care. So to summarize, I want to bring focus back to the KDIGO vascular guidelines, where the idea is to have a life plan. So KDIGO have this synonym for plan as being patient, a life plan, access, and needs. And the idea is to have a life plan in place before the dialysis is initiated, before at the pre-dialysis spot, to have a full plan during the whole life of the patient on dialysis, is to think about what the first access choice would be, what the second access choice would be, and what the subsequent choices of access would be at get-go, so that they have the best outcome going forward. With that, I'd like to conclude and want to say special thanks to Dr. Shukla and Grant Sheffield for many of their slides and help with this.